Ladies and gentlemen, I'm Judy Miller-Jones, Director of the Forum, and on behalf of our good friends at Health Affairs, I want to say welcome, and thanks to all of you for coming. I don't know what's got your tongue. I have never heard you be so quiet before a meeting, and I hope it is not indicative of what's going to happen a little bit later, because we want to have a lot of good chatter. Let me just get a few housekeeping details out of the way. As most of you know, this routine, some of you could probably say these things, it's better than I can, but let's just go through it. First of all, I think most of you have been to Health Policy Forum meetings before, but as you know, we were started many years ago as an opportunity, a vehicle to allow folks in the Congress and the executive branch to come together, to learn from each other, and to learn from folks in the field, and to meet with the best and the brightest, and to dig down deep into issues. And that's exactly what we're going to try to do today, and we'll say more about that in a minute. I didn't even do it myself, but the most important thing right now, folks, turn off your cell phone and don't talk in the hallway because it will be heard by all of us here. You have handouts in a package that list both the other folks who are in attendance here, but also the bios with information on how to connect to these people later, because we consider these folks extended family, and that's half the goal of what we're trying to do here today. When you ask a question, if you would introduce yourself, though, to the others so that the people at the podium here know who they're responding to, and also you might recognize a name but not the face, and now you'll know who you've been talking to for many years. For our purposes, we would love it if you would fill out the purple evaluation form, because we do use that in forming our agenda coming up, figuring out how best to structure meetings to be helpful to you. Please add NHPF to your safe sender list, and I know you have to do this periodically, but something about the way the government runs its filters, it's a never-ending process. Let me just say a word about this meeting. It is somewhat special. Over the years, we have drawn on experts that have published in Health Affairs. We've handed out their books. We have had a great working relationship. And we try to do something a little bit different today. We're co-hosting this meeting. We're actually taping this meeting, which makes some of you nervous. And it's not designed to make you all here nervous. But the goal is, we opened it up to some press to come to this meeting as well. So we will tape the first part of the session, and then we will do the traditional honor the dialogue that takes place by not taping that. We have found in the past, when we've experimented this way, that speakers tend to clam up, and that ain't what we like. We in fact like it when they have a tiff with each other. Very instructive. So I want to say thank you to Alan Weil for his help and for his staff's help, and Sally Coberly, who worked on our end on this. It's been a delight. But publicly, I want to say how much I think all of us in this room read Health Affairs. It ain't one of those things you just put on the desk. You're drawn into it. So, Alan, I'm going to let you do some more of the introductions, and then we'll get underway.
Thank you, Judy. I'm Alan Weil, Editor-in-Chief of Health Affairs, and I want to echo from my side of the picture the comments that Judy just made. We have always seen the Forum as a partner, and we've always been thrilled when the authors published in our journal have an opportunity to present to the audience that the Forum attracts. So we're colleagues, longstanding colleagues, but this is the first time we've done an event together. And we do things slightly different. We have slightly different audiences, but we work them through, and I don't think you all will notice any difference. And part of what brought us together, an important part of what brought us together, is the John A. Hartford Foundation that supports both of our organizations, has supported the Aging and Health series in Health Affairs. That's been a tremendous opportunity for us to expand our content in an area that's so important and that serves as the backbone of the presentations you're going to hear today. So we're really thrilled to be able to do this in partnership with the Forum, and if you watch the video after, you can thank us because we're the ones who demanded that at least the presentations be recorded, and then the conversation can be off the record. It's really a pleasure for me to introduce to you all Terry Fulmer, president of the John A. Hartford Foundation based in New York City. The foundation is dedicated to improving the care of older adults, and they have done that admirably. Founded in 1929, an endowment of a little in excess of $500 million, and a niche that makes them unique and powerful because of their focus. Terry Fulmer was the Distinguished Professor and Dean of the College of Health Sciences and Professor of Public Policy and Urban Affairs in the College of Social Sciences and Humanities at Northeastern University. Many other things to say. Received her bachelor's from Skidmore, her master's and doctoral degrees from Boston College, and her geriatric nurse practitioner postmaster's certificate from NYU. She is an elected member of the newly renamed National Academy of Medicine, formerly the Institute of Medicine. Thank you for making today possible. Please welcome Terry Fulmer.
Thank you so much for the opportunity, and good afternoon, everyone. The John A. Hartford Foundation is delighted to be working with such distinguished grantees. It's an honor and a privilege. As you just heard from Alan and Judy, we are dedicated to improving care for older adults in all venues, by all people, in all the ways that we know that care has to be advanced. And we're very excited to be listening to these important papers today and the dialogue that go with it. I'd like to just take a moment to thank Marcus Escobedo, who's with me today from the Foundation, for all the work he does on these two grants. It's very, very impressive. I'd like to just comment a couple of minutes. You mentioned our foundation, and I want to say the John A. Hartford Foundation in New York City became the wonderful conduit for those funds through the Atlantic and Pacific Tea Company, the A&P grocery stores. And so we have had a long trajectory from John and George Hartford for doing the right thing, which they said advancing care for older adults would be pretty important, and so it really, really is. We all know that. We're aware of the changing demographics. Everybody in this room is thinking about it, and that can really be seen as a major success of our century. At the turn of the century, average lifespan 40, today 80. Doubling it is pretty amazing, and we have to figure out how not only how to celebrate and take care of those individuals, and as a geriatric nurse practitioner, I think about it a lot, but also thinking about all the ways that we can be, and I love the title, efficient and effective in that care. So I'd like to simply say that these older adults are not simply living longer, they're productive, they're engaged, and all of us think about the way that we have changed the way people die from a triangle where people were moving up and then living longer but less, and now that rectangularization of aging, which means that the meaningful participation of older adults so important, and the excellent care they deserve even more important. So we'll be listening to some very exciting models, and let me say that the foundation has supported the National Health Policy Forum since 1997. And today, more than ever, we recognize the value that the forum brings in providing safe, nonpartisan space in which to deeply dive into complex policy issues. We hope you'll return next week to the forum briefing on new ways of delivering care-based and patient goals, areas that are deeply a part of our work and our interest at the Foundation. Health affairs plays a very vital role in this nation related to educating people in the health policy arena and beyond. The journal is the go-to source, as you know, for high-quality, rigorous analysis and commentary on health policy issues. And with the Foundation's support, we've been very proud of the Aging and Health series, and we thank you for that. So it's an incredible amount of innovation and experimentation happening in healthcare. I am on the board of a hospital, upstate New York, Bassett Health System, that covers 5,000 square miles, and every time I listen to one of the topics being presented today, I get excited about it, and I hope you will too. Thank you for welcoming us today, and I look forward to the speakers. Thank you.
Thank you. And as someone who grew up in Nashville, I am probably one of a small number of people in this room who's actually shopped at an A&P, but I well remember A&P stores from my childhood.
Me too. I did.
So a few of you are nodding, but not very many.
Yeah, all the ones with gray hair, yeah.
Talk about the demographics. That tells you a lot. We are thrilled to be able to have today speakers who've published in the journal, not just these papers, others as well, of course, but to highlight two pieces out of the Aging and Health series. You have their full bios. I won't read them at length, but Tom Graf, who I met when he was at Geisinger, has just recently moved to become the National Director of Population Health Management at the Chartist Group. You'll hear from David Meltzer, who's the chief of the section of hospital medicine and director of the Center for Health and the Social Sciences and chair of the Committee on Clinical and Translational Science at the University of Chicago, and a professor in the Department of Medicine as well as in the Department of Economics. The two of them will present, and as I say, they've had papers in our Aging and Health series. You'll then hear reflections on those and broader comments on improving quality and efficiency from Randy Brown, Vice President and Director of Health Research at Mathematica Policy Research, and my longtime colleague Bob Berenson, Institute Fellow at the Urban Institute. So we'll get out of the way and let you listen to them. There will be a series of presentations. It'll take a little while, but they'll be worth it, and then we will have a significant amount of time to engage you all. So without further ado, Tom, let's kick it off.
Good morning, and thank you all for coming. It's a real privilege to be here and a chance to talk about some of the exciting work that actually a team of individuals that I got to participate with at Geisinger developed this model and talk to you about the results. Just a couple of words for those of you not quite as familiar with Geisinger as a few of us. Geisinger is a 1,600 physician medical group that owns hospitals and a health plan. And I say that very deliberately because all six, and there have only been six in the 100 years of its existence, of its CEOs have been physicians. But more importantly, almost every single decision that's made throughout the enterprise has physician fingerprints all over it. The physicians really are active drivers of how care has evolved. And that isn't to say that there aren't great hospital-centric systems or great health plan-centric systems or led systems, but it is a very different environment to come from. The other thing is Geisinger is really not just a funny way to spell Kaiser. And Kaiser has done wonderful things, but Geisinger is not a closed system. So 2/3 of the people that get their care from a Geisinger physician or hospital do not have Geisinger health plan insurance. And the same is also true on the other side. 2/3 of Geisinger health plan's 500,000 members get their care from a non-Geisinger physician or hospital. And so while there is that special area that Glenn Steele used to refer to as the sweet spot, where we both provided the care and financed the care, right? I always like to describe it as you had to be sort of a special kind of stupid to screw that up, right? As long as you push the money around in the back, and if you kept the patient's interest first, you could figure out the financing later. The trick, though, is whatever you do in that special space has to work in the real world, right? The other 2/3 of the payers, we have the luxury of 4 Blue Cross plans, for instance, in the state of Pennsylvania, has to work for those payers, and for the health plan has to work with the thousands of other physicians that Geisinger works with. So it's a really interesting microcosm, and for healthcare researchers, there's a great opportunity to look at every level, right? You have patients that get their care from a Geisinger physician on the primary care side, on the specialty side, are hospitalized in Geisinger facilities, and have their care paid for by Geisinger health plan, all the way to, all the other extreme, which is only one of those 4 elements involved. And so you've got lots of internal controls, a very exciting place to work. And the journey there around improving care began nearly a decade ago. And I don't need to emphasize to anyone in this room the crisis that we have in quality, in cost, in patient experience. And I would add, actually, relative to the folks in this room, the professional experience, right? And I've told Don this, the triple aim is great, it's wonderful, it's incredibly important. We have to do that. But if we do it on the backs of the men and women that we're asking to provide that care, that will not be a sustainable system either. And so we have to make the professional experience improve as well. And we've been able to do that, and I'll show you some examples of that shortly. But that ability, we can't continue to rely on the heroic efforts of diligent individuals to get the reasonable care that we get. The care, and the panel will show you, in the United States, highly variable, right? We have some of the best care in the world and some areas where we really need to improve, right? If you look at the Commonwealth Fund data or other sources, right, we are the lowest of the developed countries in preventive health and other community health type concerns, and falling further behind, yet we spend significantly more. We're on a different plane, quite honestly, than everyone else, and continue to outstrip them in spending. And so we're clearly not getting what we should. And so we began a decade ago to think about that highly variable quality and determine how can we reliably deliver measurably better care, with the supposition that if we did it, we could do it in a way that was better for patients, better for the healthcare professionals, and cost less. And so this emphasizes, the program started in 2006, rolled out over about a 4-year period within the Geisinger system, but at the same time rolled out with these private physicians that contracted with our health plan. In fact, in 2006, 2 Geisinger, 1 non-Geisinger site were in that program, and that non-Geisinger site actually did not have an electronic health record when they deployed. They did over the course of the intervention. The other thing is the paper treats Proven Health Navigator, which is the name of our care redesign model, as a static being, which, as you'll see from the presentation, it clearly was not, right? We deployed a set of interventions in 2006 and 2007, and those continued to evolve throughout the process. So it's not a static program. Despite that, which I find fascinating, one of the most important findings is the fact that the longer there was exposure to the program, the greater the savings. Now, if you think about it, the simplest interventions occurred at the beginning, but the greatest savings. So it really is a dose-response effect, and to me that's sort of exciting. The other thing to emphasize is, although a lot of the data we're talking about today comes from our health plan and the third of the patients that we care for, the care for every single patient at every single Geisinger site changed. Right? It wasn't titrated based on their insurance company. Now, the effect may be more or less, right, because of the data flows that are available, but the idea was to change the care for every single person. The other thing is we're going to focus on the impact on the Medicare age beneficiaries, because they tended to be the sickest and tended to have the greatest improvements, but the care for the commercial patients and the Medicaid patients and anyone that came to our sites improved along similar lines. And the quality data is actually total population quality data. The number at the when I left Geisinger about 2 months ago, it was about 350,000 patients within the system, probably significantly more when you think about the other groups that have been involved. Proven Health Navigator is a medical home type program, but it's significantly different. I'm just going to roll these out. Significantly different than most programs in that it not only focused on redesigning primary care, which is critically important, and changing the payment model for that, but more importantly also focused on how we deliver specialty care, how we bring population management skills into the primary care and physician realm, and then I think most importantly focused on this issue of financial sustainability as a core component from the very outset. Right? The only thing worse than not doing this would be doing it and then having to stop because we couldn't pay for it. And I think that element of financial sustainability is incredibly important. The other thing to think about is what happens, unless what happens between the physician and the patient in the exam room or the hospital bed changes, we haven't actually accomplished anything. And so at the end of the day, it's about creating that interaction. Now, there are lots of skills that go on behind the scenes, making sure that the right patient is having that interaction with the right provider. Maybe it's not a physician. Certainly is not in all cases, right? Making sure that the sickest patients are getting the most help and the most care. Those are skills that happen in the background, but at the end of the day, we also have to change what happens in there. So that change management and physician leadership, and I've been accused in the past of being biased, are critical elements of this program. But there's certainly other things that have to happen as well. One of the things that we decided early on was to partner with our health plan to put care management not just co-located in our offices, which have been happening for a long time, typically in the broom closet closest to the exit, but really engage them in the full care of the patients that have them, putting them close to where the action is, either where the physicians tended to congregate or the phone calls tended to come in, because we wanted them an active part of the team and driving that piece. The other thing that we knew we had to do was to create the electronic infrastructure to make our EHR and the associated information services active members of the team as well. And then get everyone focused on top of license work including the patient and family, in that process. And the electronics then accelerate all of those elements. Redesigning physician work, so patient relationships and complex medical decision making occupied the vast majority of the time the physicians spent their time on, was an incredibly important piece, and then building the rest of the team out in a deliberate fashion to make that happen. One of the things that we also realized is we needed to systematically look at what quality in chronic disease was, because that's where the bulk of the spending is in this country, and that's what was driving the bulk of the medical issues that our patients faced. And then how do we reliably deliver that care to every single patient every single time? And this is the Redesign Mantra that we used. And it was first figure out what the best care is, then figure out how to deliver it, then figure out how to pay for it, both from a system level, i.e. how does the payer pay the system, and then how does the system pay the physicians. We list compensation on here last, and I do that very, very deliberately. Now, clearly, paying somebody to do X and expecting them to do Y doesn't work, right? I think we've proven that pretty well in this country. But at the same time, merely paying them to do Y and expecting them to do Y reliably doesn't work either. And we've all seen that with pay-for-performance programs where health plans are interested in HEDIS metrics and they may give you a bonus for doing colon cancer screening for a few years. And what happens? Colon cancer screening goes up, not insignificantly. And after about 2 or 3 years, the health plan gets happy with that number and they say, we're going to stop paying for colon cancer screening and we're going to start paying for breast cancer screening. And what happens? Breast cancer screening goes up. What happened to colon cancer? Goes right back down. So, if you think you can line up the cheese in exactly the right format to make the physicians dance their way through the maze, I think you're going to be sadly mistaken. What we created was a system where we used compensation to focus the physicians on participating in a deliberate and disciplined system of care. Right? It reduced some of those barriers. It brought their attention out. And then we expected the system to reliably deliver that measurably better care. And then we did a lot of other wonderful things like, stop treating the patients as passive recipients of care, but actually involve them in their care, right? What's the one group that's been shown to change physician behavior even more than drug reps? Patients, right? So if you give patients information about their care, your blood pressure's been way too high for the last 6 months. I'm not exactly sure what the doctor's going to do when he walks in the room and the patient says, "Doc, my blood pressure's too high," but I'm pretty sure he or she is going to do something differently, and overcoming that clinical inertia is an important part. The other thing is we created a safe space to really think about not just the quality of care, which we previously defined, but how that care is delivered, right? Time that's protected from the hectic interplay of the day, but really to focus on what do we do with a patient who calls and is having heart palpitations? Does every single one of those patients need to go to the hospital? Well, it turns out that the medical literature very clearly says no. And here are the criteria of the people that don't need to. And here's how you can build a system to reliably deliver that best care to the patient. So if they have X, Y, and Z, yes, they should be directed to the hospital immediately. But if they don't, bring them in and do these steps and create the system to make it easy as possible to get what we know from the evidence to be the best answer. And then you set up systems to reliably review that and report it back. So these meetings that were 90 minutes in length, and if you think about what that means for a lot of our colleagues, right, shutting down an office for 90 minutes, once a month, where everybody sits and talks about how's communication going? What's the flow of information? Do we have the right electronic supports? Right, and everyone, we played this game with the EHRs, right? You deploy EHR and magic happens, the world gets better, and soup to nuts, everything is wonderful. We've all realized that doesn't happen, right? At the same time, you need the electronics. If you don't redesign the people systems and then bring the electronics in to make them go quickly, right? If you've got a crappy system and you make it go really fast, you get a lot of, So changing the way we do the work was the important element. This was the way to make it happen. Give folks some dedicated, protected time. Now, we also brought in leadership, right, that could help guide and direct and support, and also make sure that we didn't have to reinvent the wheel at every single one of those 85 sites that we've deployed each time. So they could bring in learnings from one site and share them with sites that were struggling with the same issues. A third of the meeting was set on doing patient reviews. So this is what happened with this patient. He called us, we did this, and we never followed up. And guess what? He ended up in the hospital a week later or 2 days later. Well, gosh, if we checked to see if our intervention initially had made a difference, maybe we could have avoided that or escalated the care, done something differently or new to make that happen. So thinking through those processes in that second section, based on real patients, was an incredibly important element. And then the last piece is we reviewed the quality metrics, the utilization metrics, and the cost metrics, right? So that focus on financial sustainability was there, not prime, but part of the conversation. Clearly, one of the things that resonated with physicians was, rationing care based on medical need. Nurses, doctors, people can get behind that. That makes sense. Sicker people get more help. Okay, fine. Rationing based on insurance plan or other issues, not so much. So we tailored the approach, right? Everybody got the redesigned basic primary care. We'll talk about sort of the details of that in a second, but sicker patients with moderate chronic disease got office-based systems of care approach to making their care better and more reliable. And then the sickest of the sick, right? Maybe 20% of the Medicare age beneficiaries, maybe 5% of your commercial patients, maybe 10% of Medicaid patients need this really heavy, hands-on, high-touch approach, right? You are not going to automate those people to health no matter what you do. And I don't care how many phone apps you have, they need a lot of help in real time. But it's not just disease management in the old-fashioned sense. It's not just calling them. It's really focusing on the medical driver of their problem and making things different. And the training of folks to do that role was important and different, and part of why we had to partner with the health plan, because they understood that. They needed the entree that the physician office gave them into the life of the patient, right? Hi, this is so-and-so from Geisinger Health Plan, click. Hi, this is so-and-so from Dr. Graf's office. Much different response, and they were able to actually change the care. The other piece is the physician-nurse team working together was much more effective than either one of them working individually. And so this concept of bringing the nurses into the offices at a population level was very important. It wasn't staffed on a physician basis, wasn't staffed on an office basis, it was staffed on the population. So if there were a lot of very sick patients, more nurses were in that office. If there were less very sick patients, more commercial patients, less nurses. So it was staffed based on the population needs. And then as our program became more sophisticated, the levels of the team, we started out with all RNs, which was really great because we were focused on Medicare patients with severe chronic disease. Well, when you start playing the Medicaid game, or you start playing the commercial game, the needs are different, right? And the team needs to be different. And so allocating social work and non-clinical folks to really back up the nurses to perform some of those, again, not top-of-license nursing tasks, was incredibly important in helping us scale and improve the effectiveness. What did they do? Well, a lot of the things that we did was re-engineering the care, not just in the primary care setting, but in the post-acute setting as well. Moving medical home into the nursing home, right? Medicare patients have a 18 or 20% readmission rate from hospitals. Nursing home residents, double that. 35 up to 40%. Some of our worst nursing homes, more than half of the patients were back in the hospital within 30 days. All right, so we had to do fundamentally things different. Having a dedicated person full-time, right? Because if you think about it now, part of the problem with nursing home is, you've got ICU patients, hospital patients, office patients. Right above paperwork is where doctors tend to put nursing home care. Well, make it somebody's day job, and guess what? They did a better job. So we put advanced practitioners, nurse practitioners, PAs into the hospital, into the nursing homes rather, 4 or 8 hours a day. They went to 1 or 2 nursing homes. And they did medical home in the thing. They saw patients within 24 hours of admission, just like when patients were coming out of the hospital, we called them within 24 or 48 hours of discharge. Right? They did comprehensive med rec. They managed actively emerging exacerbations. So the heart failure patient whose weight's up 2 pounds, not 20, isn't hypoxic, doesn't have to go to the hospital, can be managed in place, treatment in place. The other thing that was fascinating is 20% of the nursing home readmissions occurred not in that early period, right? It wasn't a failed hospital to nursing home. It was a failed nursing home to home transfer. Now, clearly you will never get that to zero because there are families out there that will always say, yes, 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 and then they get grandma home and it's 3 full-time jobs and they can't do it, and then it's no, no, no. Fair enough. But a lot of those patients we certainly could manage much better, and so actively managing that handoff from nursing home to home, just like we do the hospital, an incredibly important element of what we do. The other thing that we did over time was pull the specialty care physicians into the model much more tightly. no matter how good, and I'm a family physician by training, so I, again, biased, but no matter how good you are at primary care, there's a limit. And, God made specialists for a reason. And so we need their help. And we need to do it, though, in different ways, right? The old-fashioned one-size-fits-all, I refer you somewhere between 30 days and 30 years, you're going to see the specialist, doesn't work, right? So getting the specialists involved in what I call cohort management, so they can see all of the patients that have a relevant disease, say all of the patients with CKD that are within that care system, and can implement changes to try and improve that care. Or if the if the primary care doc and the patient are in the exam room, we need the ability to bring the specialist into that encounter in real time. So now it's not a 30 to 60 day wait to see the specialist, it's 30 to 60 seconds, okay, maybe 10 minutes. But the concept of having them in that exam room consulting with and advising the primary care doc, 70% of the time we were able to actually avoid a specialty care referral. The other 20%, the visits or the intervention started sooner, or the appropriate specialist was consulted. No, this isn't a cardiac issue, it's pulmonary. You need help from the pulmonologist. Saves the patient time and energy. Very quickly, results. Quality went up. We were very excited about this. We had a 500% improvement, for instance, in our comprehensive diabetes score over a 5-year period. You guys can look at that at your leisure. What it resulted in, as Glenn would always say, did you do anything for patients? Yes, Glenn. In 1,000 days, for every 150 patients 166 patients we treated for 1,000 days with diabetes in our system of care versus usual care. This is not versus no care, this is versus usual care. We prevented a case of retinopathy. For every 140 patients, a stroke. For every 82 patients, a heart attack. And so the ability to change outcomes are incredibly important. Those things matter to patients. And guess what? Later this year we'll be publishing the results. Turns out that's 7% cheaper over 5 years, which is very exciting. Now, what did we do? Well, we drove down admissions. Why? For all those things that we just told you. We reduced readmissions in this group by up to 36%, overall admissions, the entire population by about 18%. Entire population. This is not just focused on the sickest of the sick. Now, the interventions often focused on the sickest of the sick, but the care of the entire population improved. ER, interesting story. We like to spin it as sort of remained flat, whereas the patients not in a systematic medical home in our model went up by about 30%. There's still a significant differential there. Where we're actually able to impact it in the commercial population, I just wanted to show that we could do something. The kicker to this, though, is not only did we improve care, but significantly lower costs, about 7% lower trend rate over the first 4 years of the program. 1.7 to 1 return on investment. So for every dollar we put into the program, we saved $1.70. And by the way, we improved the care of the patients at the same time. They weren't having heart attacks, they weren't having strokes, they weren't being hospitalized. As we talked about this fully functional aging and meaningful life, to me, this is where it is, right? Keeping them out of the hospital, keeping them on track was an important element, and I appreciate your consideration.
Well, that was wonderful. I'm really excited to be here and talk about our comprehensive care physician program. It's, I think, going to be a really interesting complement to what Tom just spoke about. Some very similar themes and some different ones as well. So our program is really about redesigning care for patients at increased risk of hospitalization. And I want to acknowledge the support of both the Robert Wood Johnson Foundation that provided some early work that helped us develop the concept of the model, and then also the support of the Center for Medicare and Medicaid Innovation, which supported the main study that I talked about. And of course, these are my opinions and not theirs. So I think we all know, one of the main reasons we're here, which is, of course, to care for patients, but also to deal with the problem that we have in costs. And I don't need to repeat these numbers here, but it is easy as you look at figures like this and trends like this to believe that the growth of healthcare costs is inexorable and that we'll never really make big progress. But what I think we need to remember is that there are some examples of really dramatic changes. And I think there's reasons to believe we may have more of them ahead of us in terms of improving expenditures. I know many people in the room know the history of the Medicare prospective payment system, where we went from paying just more per hospital day to just paying a fixed amount per hospitalization. And we went from year-on-year increases of 14% in Medicare hospital expenditures down to 6, 7, that level. So real change is possible. And when you try to understand, what are the forces that may drive that change, I think the research findings that we've had over the years about understanding healthcare expenditures are critical. And I think there's no more important fact in understanding decreasing healthcare expenditures or how to do it than this simple one, which is that the vast majority of money is spent by a very small fraction of people. Okay, and there are two parts of this. The first part is, in fact, that very little money is spent by the vast majority of people. And we think about patient-centered medical homes, and we think about putting everyone in a patient-centered medical home. We have to remember that our chances of making back the money we spend on most of them actually is pretty small. On the other hand, there is this subset of people where a tremendous amount of money is spent, and we can make back a lot there. And I think Willie Sutton should be our mentor here, the bank robber, right? Because why do you rob banks? Because that's where the money is. So if we want to control healthcare spending, we have to really focus on those folks. Now, so in comes the Affordable Care Act. It's going to change everything. It changes how we get insurance, and that makes healthcare more affordable for individuals, or at least insurance. But really, in terms of decreasing costs, it pushes towards a whole series of interventions in prevention, comparative effectiveness research, care integration, patient-centered medical home, for example. All of these are directly tied to changing how we deliver care. But then there's also incentives, bundling, capitation, accountable care organizations. These are payment mechanisms. They don't tell you, however, how you actually change care. And then, of course, in comes the Center for Medicare and Medicaid Innovation to really think about how we actually change care and make some of these incentives translate into actual policy changes. One of the other elements of this payment and delivery system reform that really hasn't gotten as much attention in the cost debate, though, is reinvestment in the primary care workforce. And this has been an area that's been of great interest to me from the time I was a medical student, really. And I think everyone has a sense, but maybe not the magnitude of how specialized American medicine has come. This is a figure from the Cogni report of, at this point, 15 years ago, showing essentially a flat number of generalists, a trend that really hasn't changed much, and an extraordinary growth in the number of specialists. And why should this be of concern to us? It's studies like this, the medical outcome study, that suggests that patients cared for by specialists often have higher costs and no better or even worse outcomes than patients cared for by generalists. And there are lots of reasons to criticize the medical outcome study in particular, but I think a lot of us believe that, in fact, there are real questions about whether American medicine has become too specialized. Now, I got interested in this question about 15 years ago with the growth of the field of hospital medicine. And I think people understand the concept of hospitalists at this point, but it deserves repeating. So traditionally in the United States, people had primary care doctors who cared for the patient both in clinic and in the hospital for their general medical problems. These doctors' jobs were spend the morning in the hospital seeing their own patient and rounding, and then in the afternoon they went to clinic. There was incredible emphasis on this on continuity of care and the value of the doctor-patient relationship. Interesting, as much as this was dogma in American medicine, is a model that's essentially unique in the developed world. And then in the 1990s, this all changed with the growth of hospitalists, doctors who specialize in inpatient care. Today, there are more than 30,000 hospitalists. They care for 1/3 of all general medicine admissions, and continuing to grow rapidly. And the question I got interested in is this change in specialization, yet more specialization, a desirable one? And sort of secondarily, can we figure out ways to improve care by understanding why hospitalists arose? So as I've approached this problem, I've brought to it my training as an economist. And I've thought about this from the perspective of the advantages and disadvantages of hospitalists as an example of the economics of specialization. So on the advantage side, the advantages of specialization include the inpatient focus of hospitalists, their greater presence in the hospital, the idea that they may have greater expertise because they always care for patients in the hospital. However, on the disadvantage side, it's really this loss of the doctor-patient relationship. You just don't know the patient when they come in the hospital. You have to figure out they don't know you. A whole series of challenges may come from that. In economic terms, you can call this coordination costs. And another example is the handoffs between the inpatient and outpatient doctors that are costly and often imperfect. So what economic theory would say would be that the optimal level of specialization really balances these benefits and costs. And this is a very deep concept in economic theory that goes back to literally the first paragraph of Adam Smith's Wealth of Nations, but it's not limited to economic theory. If you read the writings of Francis Peabody, the person in medicine who's known as sort of the father of the value of the doctor-patient relationship, he talks about the value of knowing the patient. But he also says, gosh, you got to know something about the kidney too. Okay, and if you watch TV, or old TV, and know who Marcus Welby was, the family doctor of the 1960s, who had this deep relationship with the patient. When you actually watch the show, you discover he struggled with the explosion in knowledge and the difficulty of doing that job. So all these theories say this is a balancing act. There is another theory, though, that I really wasn't so aware of until I started working on this. And it's one that says that when you're in this difficult situation, you have to try to adjust the model and improve it to minimize these challenges of specialization. So, for example, you can try to improve the quality of handoffs, make them better, or find ways to eliminate truly unnecessary ones. And that latter idea is really critical to another theory that I think is relevant here, and it's something that's called an adaptive organizations perspective. Okay? And it's a new idea within the economics literature, and it's the following: that when there are very high returns to specialization, so you want to be super specialized, but also really high coordination costs. So when you're really specialized, you have a lot of problems. Sound like medicine, right? What do? You focus your product to reduce the needs for coordination. You try to care for a particular group of people in a particular way. And this is what's often called a solution shop. Clay Christensen has popularized that description of it. And that really was the key idea for thinking about this problem. So as I thought about why did hospitalists grow, I wondered, can we learn something from that? Now, there were two real theories of why hospitalists grew. The first one was that they grew to meet the needs of hospital care, and this is what most people believed, that they had the incentive and ability to reduce hospital costs. Medicare prospective payment had done that. The patients were getting sicker and sicker in the hospital. You needed doctors who could be there all day and not just in the morning. And so we've looked at this. And what does the data suggest on the net benefits of hospitalists? Well, there are some cost savings, maybe $750 to $1,000 per admission, but those are probably maximum numbers. We know that the savings grow as the doctors become more experienced, but often they're not that experienced because people turn over in these jobs. And there's no data to suggest hospitalists actually have any post-discharge savings. And so it's really not as impressive, I think, as people might have thought. About the value to the patients, the outcomes are about the same. If anything, we know people prefer having the doctor they know to a hospitalist, even though they won't pay very much for this. So on that, I would say, are hospitalists a little better than a model where you have people who just do it part-time and aren't your doctor? Yeah, they're a little better. But are they a game changer? No. So why did something that's maybe not a game changer take over the marketplace? And I think the answer is this second theory, that hospitalists grew to meet the needs of ambulatory care. Over time, there were declining hospitalization rates versus ambulatory care. And this decreased the ability of PCPs to have enough patients in the hospital on a daily basis to make the trip. So they just didn't want to go anymore. Okay? And this happened not because hospitalizations fell, but because ambulatory care rose, because people were getting lots more prevention. And as physicians organized into groups, it made sense for them just to pass off the little hospital work they had left to this subset of hospitalists. So we've tested this idea formally. We developed a formal economic model accounting for doctors' time costs and comparing two models. One, the old ambulatory traditional model, where you had an internist who spent time seeing patients in the hospital and also in clinic and had to drive between the two. And the newer model with the hospitalist and the primary care doctor, where the hospitalist spent time seeing in patients, but now they had to communicate with the PCP. And the PCP spent their time seeing patients in clinic, but now they had to communicate with the hospitalist. So the difference in cost between these two models is, on the one hand, the communication costs, and on the other hand, the transport costs. And depending on which are larger in any given setting, that may determine which one is more desirable. And this formula actually lays that out. And from this, we got a very specific set of predictions. that the cost of the PCP hospitalist model compared to a traditional model would fall as admissions fell relative to ambulatory visits, so fewer patients in the hospital, as communication, which is exactly what happened, as I told you earlier. Communication costs decline, better health IT, for example. Transport costs rise, more congestion in parking lots, and so on. And as physicians worked fewer hours, and which in fact exactly has been happening, especially in general and internal medicine. We then tested these theoretical predictions, many of which were not at all obvious before we did the analysis, with data from the community tracking study. And I won't go through the details. Every one of them was supported in the data. So we concluded that hospitalists grew, at least partially, not because of the needs of patients, but because of the incentives faced by doctors. And when you see that, and these are all pictures from Marcus Welby, illustrating these, the healthy patient on the phone, unhappy in the car, and his partner who wanted to ride motorcycles and not work long hours. So when you see that this is happening, not because of the good of patients, but because of the incentive of doctors, it makes you worry, could this actually not be so good for the patient? And there is, in fact, an extraordinary literature on the value of the doctor-patient relationship, suggesting that it's incredibly important. When there's a stronger doctor-patient relationship, there's more trust, there's an interpersonal relationship between the two, better communication, better knowledge of the patients. We know patients value seeing their own doctor in the hospital. And there are some amazing studies to support the value of these relationships. Observational studies show better costs, lower costs, better outcomes with continuity of care. Patients who have been seen by their a PCP for more than 10 years have 15% lower Medicare costs. Lung cancer patients cared for by their own doctor in a terminal hospitalization have 25% lower use of the ICU, presumably futile. And the most amazing study, this study people should cite every day, is by Jack Wasson. It was done in the 80s. He randomized 800 complex patients in the VA, either to see the same doctor in every visit or a completely different doctor in every visit, primary care doctor. In the continuous care group, they had 49% lower emergent hospitalizations, 38% lower hospital days, and 74% lower ICU days. I mean, this is amazing and really suggests that discontinuity is incredibly harmful, and especially for these complex, frequently hospitalized patients who I just said we should care about. So we would think, based on this, that wherever you can provide care coordination, it's going to be a home run, right? Unfortunately, the literature is not as impressive as we'd like. This is the summary tables from the Congressional Budget Office's summaries of Medicare's care coordination demonstration programs. They looked at 30 of these programs, concluded on average they didn't save money. Some of them decreased hospitalization, many of them didn't. There were some lessons. The programs worked a little better when there was more interaction, but they typically hire a care manager. So they worked a little better when there was more interaction between the care manager and the patient, a little better when there was more interaction between the care manager and the physician. So you get the sense here that there's a coordination challenge that's arising. And thinking about how to minimize that is critical. Other lessons: target high-risk enrollees. We do that. Gather timely data on the use of care, especially hospital admissions. Focus on care transitions, as I'll say, we do that. Use team-based care, we do that, although sparingly, and keep the cost of the intervention low. So why are these programs so hard to make work? And the reason is this. If you think about these bars as the spending, right now we spend most of our money on hospital care and a little in post-acute and some on ambulatory. And we want to shrink the size of that bar. We're not going to decrease ambulatory care. So if we're going to shrink the total, we have to shrink hospital expenditures a lot because we have to make room for those care coordination costs. And it is super difficult to make those back. So what if there were somehow a way to have better coordinated care without having to hire a bunch of care coordinators? Okay, so that's what we started thinking about. And the idea was, if only primary care doctors could do the job they used to, wouldn't that be great? Well, the problem was they didn't have enough patients in the hospital. So our idea was, let's identify those patients at high risk of hospitalization and have these doctors build up a practice that only includes patients at high risk of hospitalization. So with a small panel size that they can handle only working in the afternoons, they will always have enough patients in the hospital each morning to do the job that they used to. And I want to be clear, this is not to say that care coordination isn't important and care coordinators aren't important, but here's an opportunity to provide this in a much lower cost way, for some people at least. What would be the advantages? The most frequently hospitalized patients get their own doctor in both settings. Patients value this continuity. It can decrease a lot of unnecessary care. It's much easier for the doctor. They don't have to spend time communicating, and it's much easier to see a patient you know as opposed to a patient you don't know. You don't have to say, Mrs. Jones, who are you? You can say, Mrs. Jones, what happened last night? All hospitalized patients get doctors with significant hospital experience and expertise. Patient choice can be restored. This is the model that can work practically for the physician with a small panel size. You can use this in a patient-centered medical home. You can even use this with a small primary care base to fill a hospital. What are some of the challenges? Will patients be willing to switch? Will doctors let patients switch? Will doctors do this job, and can it be economically viable? So what did we do? We started talking with physicians about how to make this work. We designed some implementation studies to figure out how to identify high-risk patients. Simple answer, have you been hospitalized in the past year is all we use. We built simulation models, and then we were funded by CMS for this CMMI study, $6 million that started in July of 2012. Let me just tell you briefly about what the key elements of the program were. We focus on high-cost patients. Patients expected to spend about 10 days a year in the hospital, measured as I told you before. We limit the panel size to about 200 patients. These doctors spend their morning in the hospital. They get a little time off in the middle of the day. In the afternoon, they're in clinic. We built an interdisciplinary team around 5 of these doctors. We do work with an advanced practice nurse, social worker, and so on, but with smaller ratios than I think you'd expect in practices like these. We keep costs very low with a small, well-connected team. We use very simple health IT, things like getting paged when the patient appears in the ER. We've been preparing for a variety of payment models. We try to really support the team. We have a very sick patient population with about 15% annual mortality rate. We use rapid cycle innovation techniques with frequent data-driven meetings. And then we've set this up with a very rigorous design. This is a randomized trial with both internal and external evaluators. So as I conclude, let me tell you a little bit about the status of this and some of the early lessons. We began investing a lot of effort in just getting it operating and working, as well as the evaluation. We've now randomized 1,600 of the 2,000 patients we want to study for this. Most of these patients have been recruited from the hospital or the ED, some from primary care doctor practices who are leaving our institution, some from the community. The panel size for these doctors has now reached about 150 patients. Each of them have about 3 patients in the hospital on any given day. I can't talk about the results publicly because it's an ongoing study, but I can give you some impressions. Qualitatively and quantitatively, I think it looks incredibly promising. We have population health metrics that are driven by an evaluation plan organized around the triple aim, focused on better care, better health, and lower costs. In lower costs, the most important element is avoiding hospitalizations. We've learned through time that you need a tremendous number of data sources to look at this. We use patient self-report. We use our own internal claims data. We're using Medicare claims data. And even Medicare claims data, we're now identifying some of the challenges because as people move into Medicare Advantage, you have to account for that. So we're working on that as well. There's an incredible need for longitudinal follow-up and analysis. Tom mentioned sort of programs getting better over time. We've seen a lot of evidence like that. That is important. And we've used throughout this data on individual patients to help these doctors improve care. We drill down to the level of the individual. We have weekly discussions of complex and informative cases. One thing I can tell you, healthcare costs are so skewed that if you saved 1 or 2 people's savings on this, you could pay for the whole program. And then we're now finally addressing longer-term issues, a financial model for expansion and sustainability. We've been working on a fee-for-service model for this where we maximize revenue, clinical volumes using things like Medicare's new CCM codes, and also risk-based contracts, including cost management, predictive modeling, working on Medicare Advantage programs, working with private employers. And finally, the future, we will have enrollment done by June of 2016, 1-year follow-up by June of 2017. We've been working on a variety of partnerships, the Villages in Florida and the University of South Florida, a large urban public hospital system, a nationally recognized leader in integrated care delivery. And then in Chicago, we're working both at our own institution and with a variety of community hospitals and safety net institutions to look at building a network that would allow us to have clinically integrated care through these comprehensive care physicians working in a competitive market where you don't need to have concentration in order to actually have clinical integration. So these doctors, in fact, do that. So let me stop there. Thank you.
So, Randy, want to put on your evaluator hat? You're welcome to stay here if you'd like. That's great.
All right. I will do that. Is that mic working yet? No.
Do we need him up there?
What do I need? Does it work now? There. Okay, that button did it. Okay. All right. So it's kind of hard to integrate the two things. I have comments on each of the papers separately. But one of the things that I noticed that neither of the papers did was cite a health affairs paper that my colleagues and I did in 2012 that identifies 6 factors that successful care coordination programs tend to have and unsuccessful ones didn't have from a series of randomized trials. And so, well, everybody likes to get their own paper cited, but the important thing really, though, is it would be interesting to see whether what you're doing, how that matches up with what we found in these different settings. And these are in very different kinds of settings. So I think that would be a benefit to the whole field, to everybody to say, yeah, okay, because the 6 things were in-person contact about once a month, okay? That's, the embedded case managers does that. Frequent contact of the care coordinator with the primary care physician. So that's covered by, if it's the same person, makes it pretty easy. Yeah, right. But patient education was another thing that I didn't hear much about. And then with motivational interviewing to get, you said, obviously you need to get patients to play ball with you to get a lot of the changes in chronic care improved. But having the care coordinator act as a communication hub, well, again, if it's the same person, that's fine. But there has to be there's always a team, no matter how you do it, and so you need that. Comprehensive medication management is essential for chronically ill patients, and having a strong transitional care program. So anyway, I think it would be useful to see that kind of linkage made. So let me take the papers separately. So the Geisinger paper, well, I'm just going to say something about the methodology first, because I'm an econometrician. And so using this fixed effects model is effectively what you're doing is a pre-post model. Because all you do, when you use a fixed effects model with the dummy for the practice, then what you're doing is you're putting all the observations in every year in terms of deviations around the mean that the clinic's own mean over time. So they're lower than their overall mean over the time period in the pre-period or above it and below it in post-period. That's progress, but it's still a pre-post model. And while using a fixed effects model controls for fixed factors that are constant over time, it doesn't tell you that the ones that you pick are the ones that are the most likely to be able to implement changes to improve outcomes. So it doesn't solve the problem the way the paper suggests that it does. So there are other ways to reparameterize the same data that you've got to do this, and I think that might be a useful thing to do. So, and we can talk about that, but now it's not the time to do that. I think it would be useful to find out more about how the Geisinger paper identified high-risk patients. How often did you reassess patients? Once somebody's in, do they stay in? That's one of the things that we ran across all the time. They're chronically ill, so they're not going to get healed, but do they stay in the,
So, yeah, great question. So the main intervention, Proof Not Navigator, applied to every patient at every site that we owned. Not every patient was in active case management for the entire time. So our nurses had a panel of about 150 patients. Roughly half of those patients stayed in virtually continuously. The other half would transition in and out.
Okay, yeah, and I thought you may have degrees about how much contact they make, or that may be...
Exactly, and some, even when they're in, some of them got contact every day, others got contact once a month.
Yeah, and some discussion of how that happens. Is it nurse judgment alone, or care coordinator judgment alone, or do you have a protocol where, it's guidance that they can override?
It's it's a nurse judgment based off of protocol development.
Okay. So, and another question that I had about this is, so your program, never mind the methodology and whether I believe the effects or not, assuming that there are some real effects there, why does your program work when models that seem similar, like Chad Bolt's guided care model, didn't work? And that was a randomized trial, and they spent lots of time developing it. It was embedded. It had a lot of the same features. So,
I'm not sure they looked at the same whole population effect. This issue of where the small number of individuals who spend the most, right? Obviously, focusing on them would be helpful. Knowing who's next year's high utilizers, high spenders would be even more valuable if you could head off that initial high.
Exactly.
So if you follow that logic back far enough, you get to prevention, which is what we did. So we included a intervention scaled and cost adjusted, right? So we used automation on prevention for the 350,000 patients. We used systems of care for the tens of thousands of patients who had moderate chronic disease, and we used high cost care management on that focused, 25% of Medicare patients.
Mm-hmm. So that raises the next question, which was, how different were the effects for your high-risk patients versus the others?
So, it's an interesting question. For the inpatient avoidance, for instance, probably 55% of that was readmission avoidance. The other 45% was eliminating the index admission. So if you think about who gets readmitted, it's the heart failure patients, the COPD patients. So something like half of the effect was on the sickest of the sick, the other half on that next tier down.
Okay, I think that's a pretty important thing, and here's one main reason why is, whenever I would talk about the findings from our studies, we almost always found that the effects were entirely concentrated in the sickest group. Even if we defined a sick group to start with, the effects are always in the sickest group. Almost every care coordination paper that's been published finds this. And people would say, well, yeah, but can't you keep people from getting to that point where they're really critical? Yeah, it sounds like a great idea, but it's really hard to demonstrate that you can actually find those people and ward off that.
So that's where that systems of care impact on chronic disease, right? The diabetes papers that we've published around reducing heart attacks and stroke rates, right? If you've got the moderately ill patients, right? Because that looked at all 25,000 diabetics that had seen a Geisinger physician at least once in 3 years. Looked at them over about a 5-year period. Not this paper, another paper, but that avoidance of a heart attack prevented that presumably, at least to some extent, some of them prevented them from moving on into that sickest cohort. So we were keeping some people, I'm sure not all, but some people from progressing along that disease paradigm.
Yeah, that's a critical spot because it's really hard to.
Because in the end, this intervention wasn't just care coordination. That was one of the 6 elements,
right? But
only one.
Right. Okay, so in order not to take up too much time, let me switch over to the other paper. Absolutely important to focus on high risk. I completely agree. But how you define it matters a lot. And the Medicare data that I've looked at is pretty different than what you're finding. Looking at just people that were hospitalized last year doesn't begin to get at the high risk cases. There are people hospitalized because they had a broken arm or whatever, and yet there are other people that. What we ended up having to do is take people with high-risk conditions and who had a hospitalization last year. So they had CHF or COPD or CAD and a recent hospitalization. Then you start to find effects of care coordination programs. So, and just having a hospitalization last year isn't going to lead to those people are not going to have a cost of $100,000 in the next year. The $100,000 is that's the top 1% for Medicare. The average of 10 hospital days per year for everybody that's hospitalized this past year is also going to, I'll be amazed if you find that. Just because I've looked at lots of Medicare data over the years. I think for the high, go ahead.
Should I respond?
Yeah.
Some of this? Yeah.
Sure,
So,
sorry.
So let me be clear. That's the inclusion criteria. Those are not the characteristics of the people who enroll. And the reality is what we're doing is we're building an actual program that exists. And when the program exists, the most important driver of costs is volume on a per capita basis. So what we're looking to do is recruit into the program a high enough risk group of people that we can keep these doctors busy enough to justify having them in the hospital.
Yeah.
And what I'm telling you is functionally this works. We are seeing it work. And the reason is you're right about the averages, okay? But who selects into the program once you offer it are the people who actually really are going to be high among that group. And so that's what is the discrepancy between what you're seeing in the claims data, I think, and what we're seeing on the ground when we actually do this. And so I think that's the key idea.
So they self-select in?
Yeah,
Okay,
yeah. So,
okay.
so basically what happens is we go out to them in the emergency room of the hospital and we say, gosh, you've been in the hospital, do you want to switch? And the people who switch are the people who know they don't have good care, who have problems.
Oh,
That's
okay.
why the
All right.
randomization is essential, because we have a highly selected population, right? And so that's why we designed it that way. And we
Okay,
see
good.
huge declines in utilization, even in the control group. Right, it's because it's regression to the mean, but I think that explains your difference between what we're seeing in your comments.
Good, that wasn't clear to me.
Yeah, that's totally fine.
Also, so by the question is where did the effects come from? The fact that what you're doing is you're trying to integrate this in hospital care and post-hospital care, and that's great. It should prevent readmissions once somebody's already there. But how is it preventing admissions to start with, unless the fact that the people that you're assigning to this program, to the treatment arm, the docs, are the ones that are really, really good, the best doctors you got for dealing with high-risk patients?
Yeah. So just to be clear, there are a couple of different definitions of readmission. The formal definition of readmission, in some senses, you were in the hospital once and you came in again, right? But the common ones we use are like 90-day readmissions or something
Whatever
like that.
time period, yeah.
Right.
Yeah.
So these patients, there are enough patients at high risk of hospitalization in our institution who've been hospitalized once that we can pull these people in. You do not have to. It's complicated to explain, but we actually have broadened the inclusion criteria slightly to include other high-risk groups of people who have not been hospitalized, but we think are at high risk. Okay, and I won't go into them in detail here, but you can broaden it to do that very well, and I think there's plenty of savings there.
Yeah, I really like some aspects of the model. I like the home visit when it's appropriate. We're finding that on independence at home to be an important factor for sure. And well, I won't take any more time. I'll let Bob weigh in here.
Is that my cue?
That's
That's
cute.
I actually have a couple of slides. Whoops, that's not my slides there. One more. All right. So what you're now going to hear are comments from a non-econometrician. Did I say that right? Did I even say those? It's actually, I'm going to wear my old hat. I'm going to give you comments from a physician. I was once a practicing general internal medicine doc, and that's where I'm going to be coming from. The first slide is to put up on the right side what Tom laid out in his article as the core components of the Proven Health Navigator program. And on the left side are what has been called the 4 pillars of primary care, the 4 C's of primary care. Barbara Starfield is most commonly associated with reviewing the literature. It's a definition that is decades old. There's a lot of proof of effectiveness of these 4 elements: first contact care, longitudinal continuity of care over time, comprehensive care for the majority of a patient's health problems, and coordination of care with other parts of the health system. And so this slide is to just show that the emphasis is in different places. Clearly, bullet number 1 on the right, patient-centered primary care, in some ways could assume all of those 4 C's, if it's actually going on. So let me go to the next slide, and here I would say, here's the rub. Most expectations, but probably not at Geisinger, of patient-centered primary care
Like Wobegon.
do not include 3 C's of the 4 C's. If you look at assessment instruments of the patient-centered medical home, such as NCQAs, but certainly not just NCQAs, you will find very little attention to first contact care, longitudinal continuity, or comprehensiveness. And if you're actually in a situation where those 3 things aren't going on, you sure better be doing a lot of coordination, because you're not there when the patient is getting his or her care. So there's a lot of attention to coordination, and some other I'm not sort of dissing the medical home. I'm trying to make the point here is that it assumes that we still have high quality primary care, and in the next slide I'm going to argue that we probably don't on a broad basis. And so something like the University of Chicago Comprehensive Care Physician Model fills a very important gap. So I found some literature. This is by no means complete. Actually, David, you had a number of references that I can go to support this, but we found a few good examples. Health Affairs articles, there were a whole series of them that the Commonwealth Fund International Survey, this is one, it found that only 39% of adults in the U.S. reported that it is somewhat or very easy to obtain after-hours care without going to an emergency department, and that only 35% of U.S. physicians reported having after-hours care arrangements. Now, that's not specific to primary care, but it is very common to hear now that primary care physicians do not take night call, even, much less have anything to do with the ER doc when their patient is in the ER. And there's very little expectation in, as I said, in the medical home that they will. Longitudinal continuity over time, Dave's already pointed to this study. Decreased length of stay and hospital costs associated with hospitalist care are offset by higher use and costs after discharge. He made the case why sort of the traditional hospitalist approach has some limitations. And then I find this quite striking on the issue of comprehensiveness. This, I think, is indirect evidence that we're losing comprehensiveness. Between 1999 and 2009, physician referrals increased from 41 million to 105 million a year, 160% increase. Now, this again isn't specific to primary care, but some of it is specialty to specialty without going back through primary care. A lot of it is primary care. And what I didn't put down here is another part of the finding was that about a half of these referrals weren't kept. So here was a patient who had
That's the good news.
It sort of, I think, points to an issue around the loss of comprehensiveness. Now, since I'm acting as a doc and not as a policy person for a moment, I get to tell anecdotes. So let me give you a few to sort of support the case I'm making. About 3 weeks ago, I met with a Robert Wood Johnson clinical scholar, what used to be a Robert Wood Johnson clinical scholar, who was in town to learn about hospital payment and asked her what she was going to do clinically with her career. And she said, become a hospitalist. I said, you're not going to go into practice? And her response was, I don't want to be a glorified case manager. That is an attitude that is, to some extent, represents what the internists who are coming out of their training. About 6 years ago or so, we did a project funded by the Commonwealth Fund and under the auspices also of the American College of Physicians to try to figure out how much it costs to do a medical home. So we needed to sort of learn what those elements were, and we were referred to the Adirondacks, of all interesting places. And we asked this very helpful sort of head of the whole thing, and also of the Rio up there, to give us a practice that would be a 0 on the NCQA accreditation, or their, whatever they call it, their recognition program, and then a 2 or a 3, which is the top tier. So we did, and we went to the 0 doc, and the 0 doc would be the doc I would want for my doc. She was in solo practice. She was about 55. She said she wasn't going to sort of invest in doing the electronic health record because she only had maybe 5 or 10 more years of practice. But then I heard her having a conversation with a patient as I was sitting in the room. And what she said is, I need you to go to the hospital, but I want you to go to hospital X, not hospital Y, because at hospital X, I will take care of you in the hospital. At hospital Y, you will get a hospitalist, and they don't let me come and have anything to do with you. And she was the doc I wanted. The other doc was like a 40-year-old guy who had given up his individual solo practice to join a group of 20, largely because it had a very sophisticated information technology, electronic health record system, and it was clear to me that what he wanted to do was manage high cholesterol. He really just wanted to do prevention and surveillance, and really didn't think much. In fact, he was telling me he was planning to not do any night call. I hope you have all read Atul Gawande's Being Immortal. I think it was terrific. And I was looking specifically. He had a number, more than a dozen, maybe 15 sort of case studies. He did have a couple that had geriatricians, but what I noted was in only one of those case studies was there any mention of a primary care physician. We are talking about people at or near the end of life who are making major decisions about how they will spend that period. In primary care, docs weren't part of the dialogue. Now, maybe it's a selected sample, Atul's a surgeon, and I don't know how we got those cases. They weren't there. What's well known, and this I now go back to my practice, is that in the hospital, you have specialists taking care of organs. You do not have specialists taking care of patients. To a large extent, the classic example is the diabetic patient who over time develops both congestive heart failure and renal failure. And the kidney docs come in and say, push fluids to keep blood flow flowing through the kidneys. And the heart docs come in and say, restrict fluids because the patient is fluid overloaded and has congestive heart failure. And somebody has to adjudicate. And I would argue that and I don't know a lot about how hospitalists typically work, but if you're a hospitalist and you don't know the patient's been in many times, but probably a different hospitalist was assigned to that patient before, you are not in the same position to deal with those specialists. You also do not have the same experience that the last time Mrs. Jones was in the hospital, we pushed fluids and she went into florid pulmonary edema, so don't do that again. That there is something very positive about what the University of Chicago notion here is to sort of have now the hospitalist, primary care, or whatever, comprehensive care physician who has standing to try to direct that care. That used to be what the generalist physician did in the hospital, and that is sorely lacking. And my last anecdote here is referencing a program that my former co-medical director at a PPO that I was part of formed. This is a program that mostly functions in Maryland. Now, this is Maryland. I don't know exactly what's happening now that Maryland's all-payer system has moved from paying the old way for admissions, essentially, to a global budget. But basically, the business model in Maryland is for the hospitalist and the ER doc to agree to admit the patient. The goal, you get paid more for admitting patients, at least under the old system, not under the new system. So they hired this company. Basically, when a patient was ready to be admitted to the hospital, this organization brought in a specialist within an hour of hitting the ER to evaluate whether the patient really needed to be admitted with their chest pain or with whatever they had. And then if they did, which was the majority of time, but they averted many admissions, to take over care for the patient in the hospital. And what was interesting, and they subsequently, often those patients migrated to those specialists for their ongoing care. What was interesting that I found about the model is the general physicians in the community didn't object. They didn't mind losing those patients. They didn't want to be on the phone at 3 a.m. talking about them, and those were tough patients, and they didn't really want to be taking care of them. So let me conclude with the following. So the reality is that we probably, for lots of reasons, have primary care docs who don't want to follow that old model of primary care. And so therefore we need programs like what David is suggesting for that subset of patients. Or alternatively, we need to sort of do some workarounds. So I was interested in Tom's notion, which I know Mayo has done for years, bring the specialist right in, right then. Don't refer the patient to the specialist. Half the time they won't keep it. Get it done right then. That's one workaround. Another workaround is docs don't want to go to the hospital. I understand it. I was in primary care practice. The economics didn't support it. We now have Skype. We have technologies. You don't have to not have anything to do with your patient in the hospital. I guess my bottom line is I think we should have higher expectations for primary care and think a little more seriously about what we are achieving with the patient-centered medical home, that we don't lose primary care in the process. But it may be that's a dinosaur's view. Thank you.
I think this has been a fabulous discussion, and it points out two things that we talk about even in the literature and certainly at our policy forums, and that is the econometric model and how you would design studies to appreciate those interactions. But then you get into the clinical nuances and the people nuances, and so you have researchers who really have incredible research skills and econometric skills, but they're also practice innovators. And we're struggling with how do we evaluate, and we're going to try to merge those two hats, which is often, I think, hard to do. You didn't talk about what's going on from the CFO and the C-suite decisions, and the number of hospitalists who are now, it's the fastest growing subspecialty that is on a contract basis, so that you can go to the hospital, but then if you're seen by a hospitalist, they're out of network very often. They don't even report to the hospital. And all these kinds of things play out with what's going on, so it's hard to decipher in the marketplace what's causing what. So I recognize we have, some of you are econometricians, some of you are clinicians, and I think there are a couple of nurses in here, I hope, yes, I know a couple. Who wants the first question? Because there are lots of them. And I think at that point we are going to stop the filming.